Good afternoon, everyone, and welcome to today's session on structural inequalities and the epidemiology of pediatric chronic pain. My name is Liz, and I have the pleasure of moderating today's session on this critical and timely topic. Chronic pain in children is a complex issue. Chronic pain doesn't affect all children equally. There are disparities in how pain is recognized, assessed, and treated. These inequalities are shaped not just by biology, but by social structures. Today's presentation will help us explore how structural inequalities shape the epidemiology of pediatric chronic pain. Our speaker, Dr. Josep Roman-Juan, is a postdoctoral fellow at the University of Manchester, supervised by Dr. Anna Hood. He completed his Bachelor of Science in Psychology at the University of the Balearic Islands in 2017 and earned his PhD in 2024 from the Università Rovira i Virgili under Professor Jody Miro, graduating with cum laude distinction and the Extraordinary Doctorate Award. In 2024, he was awarded the Pitch Louise and Allen Edwards Foundation postdoctoral fellowship and completed a postdoctoral fellowship at the University of Calgary with Dr. Melanie Noel, where he investigated the intersection between migration and pain in youth. His future research focuses on pediatric chronic pain using international data sets and machine learning to examine how individual, biological, cultural, and structural factors such as trauma, migration, and inequality affect pain in children and adolescents. Supported by the John J. Bonica Trainee Fellowship from the International Association for the Study of Pain, Dr. Roman-Juan is working to develop a biopsychosocial structural model of pediatric chronic pain to inform better prevention and treatment strategies. Please join me in welcoming Dr. Josep Roman-Juan.
Yeah, so good morning. Thank you, Liz, for your kind words. And the presentation is a pleasure and an honor to be here sharing the research I have been doing over the past 5 years in such an important stage, an important institution, not only in Canada, but worldwide. And yeah, my aim today is to share with you some of the studies we have been publishing with Professor Jordi Miró at the University of Rovira i Virgili, Melanie Noel at the University of Calgary, and share with you the research we are currently doing at the University of Manchester with Dr. Anna Hood, essentially focusing on chronic pain disparities in youth and how structural inequalities contribute to both the chronic pain experience in this population and to create these chronic pain disparities. Basically, the data I'll be presenting you today come from 3 major studies that we conducted. The first one is a big epidemiological study that we conducted in Spain, focusing on pediatric pain. This was the second study that was conducted in this country on this specific topic. The second major source of data was the WHO study that we actually didn't conduct. This WHO study is a cross-sectional survey that is conducted more or less every 4 years, and that has been conducted since 1984, more or less, until 2018. And the aim of this study is to track the health and well-being of the adolescents. And the third major source of data is the National Survey for Children's Health from the US, which is also a sectional study that is conducted on yearly basis, more or less. It began more or less 2 decades ago. Yep.
Slides aren't changing. Are they meant to be changing?
No, I know. Yeah.
Someone flagged a question.
Thanks for checking in.
Yeah.
But before getting into that, let me build up on the presentation that Liz made. I was born, let me actually use the laser pointer. I was born in this tiny island over here. They just 60,000 people live there, so it's like a very tiny space, but I am so fortunate to having been born there, having been raised there, because I had access to multiple resources, good education. I had like a huge family support. I still hang out sometimes with my friends. This is actually a picture that Dr. Melanol took with the three of us. This is Anne Mulders from Maastricht University. They visited me a couple of months ago, and they had the best time. So if you consider a plan for a vacation, you should definitely check coming to our land. When I was 17, I moved to this other island over here because unfortunately we don't have our own university. So I wanted to pursue a bachelor in psychology, so I had to move. And I was able to do that because my parents could afford it, because they rent a room in a shared apartment. They paid for 4 years. During 4 years, my bachelor's fees. And when I got my bachelor, I was able to cover these expenses. And after getting my bachelor's and my master's in health psychology, I moved to this other place over here where I joined Jordi Miro's lab at University Rovira i Virgili. And this is when we started the epidemiological study I was mentioning you before. And that's where essentially the adventure in chronic pain started. So in summary, throughout my life, I have had, and I still continue having many opportunities, access to education, quality, like healthcare of good quality, and other resources. And I just turned 32 months ago, and I'm enjoying the best time. But I'm saying that because, as you know, this is not the reality for many millions of people around the world, because as you know, the world can be really unequal. It is shaped by structural inequalities, and depending on where you are born or live or grow up, you will have a very different experience that will end up leading to very unequal outcomes. I was attending a Pitch to Go event last week in Montreal, and I was listening to the keynote of Dr. Srividal Iyer, and she shared with us the same slide that you could see here that she took from this webpage over here, Our World in Data, just showing how unequal the work we're living in can be. For example, just to give you some examples, the average income in Qatar is literally 172 times higher than the average income in Central African Republic. The expected years of schooling in Australia are almost 23. That's 4.7 times higher than the expected years of schooling in South Sudan. And the mean years of schooling in Germany are expected to be 14.1. That's 9.4 times higher than in Burkina Faso. When it comes to unequal outcomes, just to give you some examples, the life expectancy at birth in Japan is expected to be 84.1 years. That's 1.6 times higher than in Sierra Leone. And this is a big one. The mortality rate of children under the age of 5 is 60 times higher in Somalia, where it almost reaches the 13% compared to the 0.21% in Iceland. But what do we understand by structural inequalities and health inequities? Because these are the main concepts we are addressing in this presentation today. And I'm sure that if you Google structural inequalities and health inequities, you will find different definitions. But I guess we can all agree that structural inequalities are systematic patterned differences in power, resources, and opportunity that are embedded in institutions and social systems, which result in unequal exposures, vulnerabilities, adversities, and outcomes such as health-related outcomes across different population groups. Some examples of these structural inequalities, and the examples I'll be focusing on today, are gender inequality, income inequality, and an important one, an increasingly important one, which is xenophobia. These unequal outcomes, these unequal health-related outcomes are also known as health inequities, which are the unfair and avoidable differences in health outcomes, which are often predictable based on social factors resulting from these structural inequalities. These health inequities are unfortunately disproportionately concentrated or borne by marginalized subgroups, which are these populations that experience systematic disadvantages, social exclusion and discrimination based on their identity or circumstances. These disadvantages then ultimately result in them having unequal access to the resources and opportunities, leading to poorer health-related outcomes compared to more privileged groups. Importantly, these populations can be marginalized based on several factors, such as the racialized identity, the religion, the ability, the age, the sexual orientation, and the three identities I'm focusing on today: gender identity, socioeconomic position, and the migration status. Unfortunately, and despite its lifelong impact, chronic pain and chronic pain inequities in children and adolescents have been largely overlooked as a direct consequence of these structural inequalities. And this is unfortunate because, as we know, chronic pain in this particular population is not just a matter of immediate distress or disability. We know that chronic pain can act as a crucial driver for other severe health-related conditions, as these publications from Dr. Melanie Noel and colleagues have shown. In these two studies, for example, chronic pain led to severe scores on suicidality, and these scores were significantly higher among those youth that reported additional or higher number of adversities. Also, as we know, studies using both community and clinical samples of children and adolescents have shown that over half of these individuals will continue experiencing chronic pain as adults and will continue experiencing the long-term difficulties associated with chronic pain. For example, this particular paper that was published very recently showed that these young adults that were once children and adolescents with chronic pain are, for example, less likely to complete a high school or earn a college degree, and more likely to struggle in the job market, missing out on employer-provided benefits, needing public aid, report lower quality of romantic relationships, and are more likely to experience difficulties in establishing independent adult lives. And zooming out to the global scale, to the global picture, chronic pain conditions such as low back pain, headache disorders, rank among the top causes of years lived with disability worldwide, along with other major health disorders such as depression disorders. And this applies for both sexes, for males and females. Unfortunately, and this is already data from the Spanish epidemiological study I was mentioning before, and also the WHO study, chronic pain in this population can be more common than we may think at first. For example, in this paper that we published in the Journal of Pain 3 years ago, more or less, we saw that in a sample of 1,100 children and adolescents, 46% of them reported some sort of pain that they were experiencing on a weekly basis, and that lasted beyond this 3-month threshold that allows us to classify this pain as chronic. At the largest scale, at a European and North American scale, that is the WHO study, these researchers took data from national representative samples of adolescents from 42 different countries and regions, mainly in mainly in the US and Canada and different European countries, and saw that the rate of adolescents reporting some sort of pain on weekly basis in a time range of 6 months was of 44%, so big rates here. Importantly, in both the epidemiological study we conducted in Spain and also in the WHO study, so in both in a small and a larger scale, we see that chronic pain in this population is not equally distributed, as marginalized groups, for example, girls, individuals from lower socioeconomic positions, and youth with a migration background experience a significantly higher burden. The data from our epidemiological study in Spain showed us that for those participants that were classified as experiencing any sort of chronic pain, 61% of them reported to be girls compared to 39% that reported to be boys. And for those that were classified in a group as having or reporting chronic pain that is of high impact, which is the sort of pain that is significantly associated with higher levels of intensity, interference, and disability, this gender gap increased significantly. We had 87% of the participants reported to be girls compared to 13% of the participants that reported to be boys. In this WHO study, the gender differences in pain remained consistent, as you can see in the different chronic pain conditions. The rates of girls reporting this sort of pain were significantly higher than the rates of boys for all these chronic pain conditions. But this is not surprising at this point because these findings, like the one that girls report higher rates of chronic pain, has been shown to be consistent in many, many different studies and also in these two systematic review and meta-analysis. The other marginalized group we have been focusing on are youth from lower socioeconomic positions, which unfortunately is a very, very substantial group. In Canada and in the US, according to Stats Canada and the US Census Bureau, in these two countries, 10% of the population live beyond or below this poverty line, which means that in Canada, there are 73,000 individuals under the age of 18 living below this poverty line. And in the US, that means that more than 7 million of youth are living below this poverty line. Data in Europe is like way more dramatic. Apparently, this data was updated this year in 2025, in May 2025, and apparently 24% of children and adolescents are at risk of poverty and social exclusion. When it comes to research examining chronic pain disparities between these groups of youth between or from different socioeconomic positions, there's not as much research as we see in gender disparities. But we were able to find this big study from the WHO study that was conducted almost 2 decades ago, but it's still relevant. In this study, researchers used data from almost 200,000 participants from 37 different countries. And they saw that those individuals, those adolescents from lower socioeconomic positions had between 40 and 91% higher odds of reporting some sort of these chronic pain conditions compared to individuals from higher socioeconomic positions. The last increasingly marginalized group we have been focusing on are migrants, which is a population that is rapidly increasing. According to the International Organization for Migration, according to the last report that was published for this organization, just 5 years ago in 2020, there were across the globe more than 280 million migrants. 10% of them were children and adolescents, individuals under the age of 18. So 5 years ago, there were more than 28 million migrants worldwide. And as I was mentioning, this is a population that has been rapidly increasing because according to this report, the increase of this population has been of 187% over the past 2 decades. And it's a population that is expected to keep increasing because of many circumstances that are happening, such as political unrest, the global warming, for example, the wars we have in Europe between Russia and Ukraine or Gaza and Israel. To put you an example concerning Canada and the US, in the next decade, immigrant children and adolescents in Canada are projected to represent between 39 and 49 of the total population in this age group, according to the Stats Canada. And according to the US Census Bureau, by 2060, about 1 in 5 US residents are projected to be foreign-born. Researching chronic pain disparities between migrants and non-migrants is even scarcer than between individuals from different socioeconomic positions. When we conducted this study in Spain, when we published this study, we saw that before doing that, there were less than 10 publications on this topic. And as you can see in the Spanish sample of children and adolescents, migrant adolescents had 91 higher odds of reporting chronic pain compared to non-migrant children and adolescents. And this association remained consistent also when considering this chronic pain that was of high impact. At a larger scale, when looking at the European Union and when using this data from the WHO study, we continue seeing that the pool prevalence of chronic pain among migrants was significantly higher than the prevalence of non-migrants. But importantly, there were, as you can see in this plot, that there were substantial country-level variations. To highlight just 2 examples, in Bulgaria, we found that the prevalence of chronic pain in migrants was 2 times higher than the prevalence of chronic pain in non-migrants. And interestingly, I highlighted here the case of Iceland because surprisingly, migrants reported lower rates of chronic pain compared to non-migrants. Obviously, we are focusing on the US, given the sociopolitical climate in the country. And using data from this study I was mentioning you at the beginning, the National Survey for Children's Health, we selected the cross-sectional surveys that were conducted between 2017 to 2023, so encompassing 2 very different political administrations. And we built this full model comprising children and adolescents in both these political administrations, and after accounting for the effects of many different factors, such as the sex of the participants, the age, the racialized identity, the family income, the household language, the current insurance, the parental education, and other factors, we saw no differences in the rates of chronic pain between migrants and non-migrants. But surprisingly, we found an interesting, significant interaction effect between the administration period and the migration background when predicting the presence of chronic pain. We wanted to follow up on this interaction effect. So what we did is to compare the rates of chronic pain between migrants and non-migrants between these 2 different administration periods. And when taking the non-migrant population during Donald Trump administration, we see that migrants living during this same political period had a higher likelihood of reporting chronic pain compared to non-migrants. And interestingly, both migrants and non-migrants living during Biden's period reported significantly lower ratios of chronic pain, as you can see in this plot over here. So until here, we have reviewed a little bit how chronic pain is unequally distributed across different marginalized subgroups in youth, but how can we examine how structural inequality produce chronic pain and chronic pain-related inequities? One way to do it is through an ecological analysis, which is a methodology that is very popular in social sciences, but not quite popular yet in clinical sciences such as psychology or even pain sciences. Just to give you a summary of what ecological analysis is about, you just have to aggregate the prevalence of a certain condition, let's say chronic pain, at the community level or even at the country level, and then you link these aggregated prevalence rates to a country level indicator of any structural inequality, like these authors did with the gender inequality. This is actually a very interesting study that was published almost 2 decades ago, in which the researchers using this WHO study linked national level percentages of both girls and boys with somatic health complaints, including pain, and they linked these aggregated percentages to different measures of gender inequality, including the Gender Empowerment Index and the Gender Developmental Index. And after that, they examined the association between these indices over here and the percentages, the aggregated percentages of boys and girls reporting somatic complaints. And as you can see in the table over here, the authors found negative associations between these two variables over here, meaning that in those countries with higher scores in gender empowerment measure, which is a measure again of structural gender inequality. So the authors found this negative association, meaning that in those countries with higher gender equality, the percentage of both boys and girls with somatic complaints was significantly lower. The authors also examined the association between the gender rate difference. This is the gap between the percentage of boys and girls reporting health complaints. And they found a significant association between the Gender Developmental Index and this gender rate difference, meaning that in those countries with higher structural gender equality, the gap between boys and girls is significantly narrower or smaller. So taking this previous article as a reference and using the same WHO data and this ecological analysis, we wanted to examine the association between structural income inequality and chronic pain prevalence at the national level, and a measure that is called Slope Index of Inequality, which is essentially a measure that we created to represent how different is chronic pain, or how unequally is chronic pain distributed across different socioeconomic positions. So what we did is to use these WHO surveys that were conducted at different years. We aggregated chronic pain prevalences at the country level and the slope index of inequality. And then we linked these two measures over here with the Gini index of income inequality, which is essentially a measure that tells you how wealth is distributed across a population in a certain country. So after linking these two measures over here at the country level for each specific survey of the WHO study, we tested this association controlling for the gross national income for each specific country. And as you can see on the table, this is just a summary of the results of the study that you can access through the QR code you see on the screen. We saw a positive association between the Gini index of income inequality and the prevalence of chronic pain, meaning that in those countries with more structural income inequality, the prevalence of chronic pain was significantly higher for the overall population of adolescents, not just those from lower socioeconomic backgrounds. And we also saw, as you can see on the screen, a significant association between the Gini index of income inequality and the slope index of inequality, which means that in countries with higher structural income inequality, the gap between those from higher and lower socioeconomic positions in chronic pain significantly increased. Given that we had data from different surveys that were conducted at different years, we were interested in examining if the changes over time in this Gini index of inequality was associated with changes over time in both the prevalence of chronic pain and also the slope index of inequality. And when we did that, we didn't see a significant association between these changes in this index and changes in the prevalence of chronic pain for the overall population. But we saw a significant association between changes over time in the Gini index and the slope index of inequality, meaning that if we change how we distribute the wealth across the countries, we will be able to change how chronic pain is distributed across different socioeconomic populations. Another way to examine the effect of structural inequality on chronic pain and chronic pain inequities is actually linking these indices of structural inequality at the individual level. That means without aggregating the data at the national level. And this is what these authors did for this study, examining the effects of an index of migrant integration policies and depressive symptoms among migrant and non-migrant youth. These authors used this index, which is essentially an index that gives you information about how integrative or exclusionist these policies are. It is a measure that is comprised by different indices of different policies, such as labor market mobility, education, political participation, access to nationality, family reunion, health, permanent residency, and anti-discrimination laws. And as you can see in this plot over here, what these authors did was to examine the association between having a migration background and reporting depressive symptoms in 3 different kind of countries that they classified as inclusive countries, assimilationist countries, and exclusionist countries. And they saw that migrants reported a higher rate of depressive symptoms just in the countries that were classified as exclusionist. They didn't find these differences in these other countries over here after accounting for the effect of a bunch of other factors. Again, taking the previous study as reference that was conducted with the WHO study, and this time using the National Study for Children's Health in the US, we wanted to do more or less the same, but instead in Europe, in the US. And to do that, we used this new structural xenophobia index that was created by Golim Samari and colleagues, and an index that they very kindly shared with us. To create this index, these researchers created different state-level policies from different domains as exclusive, which they coded as -1, neutral, which they coded as 0, and inclusive, which they coded as 1, and created this score that essentially ranged from -11 -11 and plus 11, with lower scores, suggesting a higher level of structural xenophobia. But for the ease of interpretation of the results I'll be sharing with you, we reverse coded these scores, with higher scores representing more exclusionist policies and lower scores representing less exclusionist policies or more inclusive policies. So again, using this national survey for children's health in the US, this time just selecting the sample of migrant participants, which was more or less comprised by 7,000 children and adolescents that represented more than 17 million of children and adolescents living in the US between 2017 and 2023. We examined the association between this IPC index I was just explaining to you a slide ago, while controlling for a bunch of variables, including, again, the sex of the participants, the age, the socioeconomic position, the family structure, the presence of anxiety or depression disorders, and other covariates. And as you can see on the screen, we didn't see, again, a significant effect of these IPC scores on the prevalence rates of chronic pain in this migrant population. But again, we saw a significant interaction effect between the administration period and these IPC scores, suggesting a significant and positive effect. That means that a negative effect of these IPC scores during the Trump administration. Following up and to get a better understanding of this interaction effect, what we did is to create 3 different categories of this IPC index, reflecting scores one standard deviation below the mean, one standard deviation within the mean, and one standard deviation above the mean. And we combined this new variable with the administration term variable and saw that taking the category Biden's administration period and IPC scores between or within one standard deviation, migrants were more likely to report chronic pain during the administration, during the Trump administration period in those states that had IPC scores within and above one standard deviation, as you can see here on the plot. This is still data that is, we are currently working on it. So perhaps we will keep elaborating on that a little bit more, but hopefully we can share with you a full publication sooner or later. Even though this study does not directly examine the influence of structural inequalities on chronic pain or on chronic pain inequities, I really want to share it with you because I truly think it is very important. It's very meaningful as it provides evidence that these structural factors embedded in public attitudes, policies, and cultural norms can really create an environment where immigrants are systematically disadvantaged and exposed to greater health risk. What we did in this study was to use this WHO study and we linked to the individual level data a composite score that we created using these 3 questions that you see over here that were part of a survey that was conducted as part of the European Social Survey. So the European Social Survey is a study that is conducted more or less every 2 years that collects national representative samples of adults from different countries. And again, these were part of the items of this survey, assessing attitudes of the population towards migration. For example, would you say that it's generally bad or good for the country, for the country's economy that people come to live from other countries? Is our country made worse or a better place to live by people coming to live here from other countries? And would you say that our country's cultural life is generally undermined or enriched by people coming to live here from other countries? So essentially items assessing attitudes towards migration. So again, we use these 3 items to create a composite score of anti-migration attitudes, and we linked this score at the individual level of the WHO study, and we assessed the association between these scores and the presence of chronic pain. And as you can see here on the screen, as we would expect, we found a positive association between these anti-migration attitude scores and the presence of chronic pain among the migrant population living in in Europe, meaning that in those countries with stronger anti-migration attitudes, immigrant adolescents are more likely to experience chronic pain than those migrants living in countries with not that strong anti-migration attitudes. Interestingly, we also saw a significant interaction effect between these anti-migration attitude scores and the socioeconomic position of these migrants, meaning that in those countries with stronger anti-migration attitudes, adolescents are at higher risk of reporting chronic pain, but this risk is even higher for those adolescents, immigrant adolescents, from lower socioeconomic positions. But as we know, structural inequalities do not operate in isolation. Rather, they intersect to create unique and often compound experiences of inequity for individuals. And this is why in a study we recently conducted, and that is currently under review, we used this WHO data and we applied a novel intersectional methodology, which is called the multi-level analysis of individual heterogeneity and discriminatory accuracy, which is a methodology that is becoming very popular in social sciences, but not that popular still in clinical sciences and pain sciences, to examine how gender inequality, national income inequality, and migration policy indices intersect to shape the distribution of chronic pain across different social identities, including gender, socioeconomic position, and migration background. To examine this intersection systematically, what we first did is to categorize the different social characteristics, social-demographic characteristics rather, essentially individual level variables and structural level variables, structural inequalities into different groups. We coded migrants, girls, and those from lower socioeconomic position as 2, and non-migrants, boys, and adolescents from medium with medium and higher socioeconomic positions as 1. The same we did with the structural inequalities. We categorized those countries with more restrictive policies towards migrants, those countries with higher gender inequality, and those countries with higher income inequality as 2. Those countries with more inclusive policies or less restrictive policies as 1. Those with lower gender inequality and income inequality as 1. And so with this procedure, we were able to create 56 out of 64 possible strata that looked like this example I'm showing you on the screen. So for example, the stratum coded as 221121 represented the group of migrant girls from medium height socioeconomic position, living in countries with less restrictive migration policies, higher gender inequality, and lower national income inequality. After doing that, after categorizing the structural and individual level variables, we applied this very new and fancy methodology, the MAIDA analysis, to calculate the predicted prevalences of chronic pain for each intersectional stratum. And as you can see on the table I'm presenting, is that the predicted prevalence of chronic pain for the most, let's say, privileged groups, which are boys with a medium, higher socioeconomic position, non-migrants living in countries with lower gender inequality, lower income inequality, and less restrictive migration policies. The predicted prevalence rates were almost 6%. But if you check the prevalence rates, the predicted prevalence rates of the most marginalized group, that is girls from lower socioeconomic positions, being migrants, living in countries with higher gender inequalities, higher income inequalities, and more restrictive policies, these predicted prevalence rates increased up to almost 23%. So essentially 4 times higher than the most privileged group. After that, what we wanted to test was if the intersection of these multiple structural inequalities and social identities actually produced compounded effects, which according to this analysis, the MAIDA analysis, this would mean that the predicted prevalence of chronic pain at these intersections was significantly higher than what would be expected by just the sum of the additive effects of each individual and structural inequalities. And in this table, as you see in the results from the MAIDA model, we calculated the residuals or the deviations, the actual deviations from what would be expected if these social identities and this structural inequality variables simply added their effects independently. When this deviation is statistically significant, which is the case for these 7 strata on the table, this suggests that the intersections of this variable had a compounded effect or had a real interaction effect, a really real multiplicative effect. So to wrap up, in conclusion, as I shared with you, chronic pain and chronic pain inequities are rooted in structural inequalities. They are not just a consequence of individual level biological factors, psychological factors, behavioral factors, or even social factors. As we saw gender inequality at the societal level amplifies somatic complaints, including pain in all adolescents, not just girls, but especially in girls. Income inequality increases the burden of chronic pain for the overall population of adolescents, especially among those youth from lower socioeconomic backgrounds. And as we are seeing, xenophobic policies and migration-related stresses exacerbate pain risk in migrant adolescents. So if these results are replicated in the future, that would give us solid evidence that we really need to address the policies that govern these structural determinants of health to really reduce both the chronic pain and the chronic pain disparities at the community level. And as you saw in the last study, our findings, again, if replicated, support the intersectional public health strategies targeting multiple layers of inequality. But as any other study, these studies I presented are not free of limitations, and I want just to highlight some of them. First, the ecological fallacy, the findings at the group population or at the national population that applies to the study of in which we examine the association between national income inequality and chronic pain. That these findings may not accurately reflect real associations at the individual level, and inferring associations at the individual level can lead to incorrect conclusions. As I said from the beginning, we use data mainly from cross-sectional studies, so causality cannot be inferred here. That limits us, highlights the need of future research to actually test the causal associations between these structural inequalities and the onset of chronic pain and the creation of these chronic pain related inequities. We also had limited external validity, as most, if not all, the research that we have been conducting has used data from participants living in Western countries, so we don't know actually what's happening in the global South, for example, or in low and middle income countries. So this is another space for future research, and unfortunately, neither the epidemiological study we conducted in Spain or the WHO study represents all the different marginalized groups that we know that exist. Research is like the research we conducted is limited mainly to gender as a binary variable, not even representing all the gender identities, the social position, the migration status, and often excludes the racialized identities, indigenous youth, other gender identities, as I was mentioning, and other intersectional groups. So this is, again, another space for future research. And speaking of future research, that's we aim to do in the next 2 years, thanks to the IAS fellowship we recently got with Anna Hood and Dr. Melanie Noel. In the next 2 years, we want to really understand how these structural factors interact with other different levels of the individual, let's say the interpersonal level and intra-individual level, with cognitive factors, emotional factors, biological factors, so to really understand how these different levels interact to end up producing the chronic pain experience and creating these chronic pain disparities. So, and yeah, we want to do that with international data sets, international longitudinal data sets, using appropriate models, novel models to do that. So, for example, machine learning techniques. So yeah, stay tuned, because more research is coming soon. And just to say thank you to the sponsors and funding sources that I had and I still have for my research, and thank you in the Jordi Miros lab and the beautiful collective I'm collaborating with to make this research possible. And yeah, thank you for your attention, and thank you again for the invitation.
Thank you so much, Dr. Josep Roman-Juan, for that thought-provoking presentation. If you're in the room and if you have any questions, please feel free to raise your hand. If you have any questions virtually, feel free to put in the chat box and we'll try to get as many as times allowed. So in 12 minutes.
Thanks. I was just saying, like, what an incredible body of work that you have here. And you've looked at this issue from so many different angles, and it's incredible to see it all brought together here today. I'm curious, based on the research you've done in your own experiences, when we're thinking about these inequities in different cultural contexts, we have like our Western kind of North American context and then the European one. Do you think that there are any differences in terms of what's contributing or exacerbating some of these, like worsening chronic pain and whatnot in these different contexts? Do you think we need to study the exact same things? Is there nuance across contexts? Yeah, just curious what your thoughts are on that.
So you mean if that maybe the inequalities that are driving disparities in the US are not the same that the inequalities are driving disparities in Europe? Is that?
That's like my curiosity. Like, do you think that that's true, or do you think that it's the same?
Honestly, I don't know. I would suggest that maybe, since the characteristics of these two countries are very similar, but I guess we could examine that for Europe and compare it to North America. That would require, for example, because this is like all this, the analysis we have been doing are country, like at the country level. So it's kind of hard to examine if this is like these inequalities are driving these issues specifically in the US compared to the rest of the countries, right? But I would assume that yes, because this is another Western country and this is like very similar to the European countries. But yeah, an interesting question to address for sure.
Do you think it's like a worthwhile question? Like, do we need to go that granular, do you think? Or is general kind of okay for where we're at right now?
Honestly, I think it's like we can extrapolate what's happening in Europe to the US, because like the same is happening in Canada as well. So I don't know the extent to which it's necessary to go at that level of like be that specific. But I guess we can always do it. We can always try it. But thank you.
Thanks, Joseph. And there's a question in the chat box. What abundance of insights and jewels here. I am wondering if variable moderators will explore around tertiary dimensions, for example, youth of single parent homes or marital status of parents. Thanks, Anna.
Quick answer, no. We haven't checked or examined these interaction effects that you're suggesting. And unfortunately, we weren't able to do so in the epidemiological study we conducted in Spain and with the WHO data, because this variable is not provided. We didn't collect data actually in Spain about that. But we can do so. Actually, there's a slide. There you go. So yeah, this study like specifically contains data about that. Here you have the family structure. So we can definitely do that. Like this is data that's like analysis that we are still conducting, and we are looking forward to examine these effects from a more intersectional lens. So we definitely plan to include this family structure as a moderator variable for sure. Thanks for the question.
Thanks so much, Joseph. And Dr. Fiona Campbell also has a question. Feel free to unmute yourself. Thank you, Fiona.
Thank you so much. That was an amazing presentation, Josep. I'm just retired as being the medical director of the chronic pain clinic at Sick Kids, and I'm co-director of the pain center. But we have a great disparity here, like great social inequities, and you've highlighted a few. Yet in our chronic pain clinics, we tend to see a high income white patients. And I'm just wondering if you've done any work on this and any thoughts on how we can ensure that we get to see the patients who need it most. Thank you very much.
Thanks for your question, Fiona. I haven't done any work on that yet, but I guess it's just a matter of making the healthcare more accessible to these people that experience these barriers that I was mentioning at the beginning of the presentation. If we don't do that, then we will continue just seeing these wide, high socioeconomic patients to like in our clinics, right? I haven't done any work on that because like the work I've been doing is like pretty epidemiological. I haven't done work in like with clinical samples yet, but I'm looking forward to do it too. So hopefully at some point I'll be able to answer your question with more details and with some data. But thank you for the question, Fiona.
Thank you so much.
Dr. Lisa Isaac has also a question. Amazing talk, thank you. Do you think there may be an association between adverse childhood events and immigration that could influence association between migration status, policy, and high quality?
I'm really glad you bring this up, Lisa, because we are about to publish a topical review on this very matter. This topical review focuses on the intersection between trauma and chronic pain in this migrant population. And for what we have seen reviewing the literature is that, yes, migrants, especially in the US, report higher rates or higher number of adversities compared to non-migrants. And there's not much literature on what adversities are impacting more the chronic pain experience, if the adversities experienced before the journey starts or the adversities that they experience once they arrive in the destination country. There's some research done in adults suggesting that the adversities that matter the most are the ones that the adults experience once they arrive, not before the departure. So looking forward to dig into this topic deeper as my research continue. So hopefully I'll be able to answer this in the next few years. But thank you again for the question, and yeah, stay tuned because this topical review will be published before the end of the year. So thank you.
Thank you so much, Joseph. Thank you, Dr. Lisa Isaac. Okay, so as we wrap up, I want to extend our sincere thanks to Dr. Joseph Roman-Juan for sharing his expertise with us in delivering such a thoughtful and insightful presentation. I would also like to thank Child Health Evaluative Science for sponsoring today's event. And also thank you so much for members of the audience for your patience and resolving technical glitches as well. Thank you everyone for your commitment and also continuing to equitable care in chronic children's pain in your own ways. Thank you.